This video is part 2 of Chapter 10, Abnormal Psychology for PSY 110S, the Psychological Sciences. In this section of the chapter, we're going to look at some of the major categories of psychological disorders. Please recognize that we're not covering all of them. Even in an undergraduate course on abnormal psychology, you're going to hit many more of the categories that are presented in the DSM, but even there, you won't be studying every single one of them in great detail. So we're barely going to be scratching the surface, but your authors want to give you a sense of how psychologists and psychiatrists talk about and define and identify, and then eventually how they treat these various categories of disorders. The first category that is presented in your textbook is the anxiety disorders. The first thing you need to understand about anxiety disorders is that anxiety is an experience that all people have. All human beings experience anxiety at one point in time or another. And as such, anxiety is a normal human experience. But there's a line over which people cross that suggests that anxiety is problematic. So when anxiety becomes excessive, when it becomes overwhelming, when it interferes with people's everyday lives, when it causes disturbances of mood and thinking, when it causes people to have to make choices like avoiding social interactions that interfere with their ability to achieve their goals, then we consider anxiety to be disordered. Anxiety and fear, as described within this category, means that you have inexplicable, overwhelming, intense experiences of fear and anxiety that interfere with normal everyday life. This differs from, the disorders differ from one another in terms of the kinds of situations or the kinds of prompts that may initiate an anxiety reaction, but they all share that emotional experience of anxiousness and fear. Anxiety disorders run the gamut from specific phobias, like phobias of small spaces or of specific animals or insects, for example, to more broad experiences like social anxiety, which used to be called social phobia, but it's not a true phobia. It's anxiety in social situations where you might be evaluated. Agoraphobia, panic disorder, and generalized anxiety disorder. Of these, generalized anxiety is common and is often difficult to distinguish from healthy reactions to a world that is a bit chaotic, but we'll talk about that a bit as we go forward. Specific phobias involve a clear, persistent, overwhelming fear of specific types of objects or situations. So being afraid of spiders, like I dislike spiders, but if I have to interact with spiders, I can manage it. If I were phobic of spiders, then it would cause me to alter my behavior in such a way that I could avoid any and all possible contact. If I have contact with spiders, I would become overwhelmed with fear and may experience a panic attack or a fear attack, and so on. Some of the most common phobias are of animals, heights, storms, water, flying, crowds and closed spaces are probably the most common. But there are lots and lots of different specific phobias that people can experience. The overall prevalence rate is about 7 to 9%, depending on which survey you're looking at. There are higher prevalence rates in younger people than in older adults, and one hypothesis for why is that as people age, they tend to find either workarounds ways around their fears, or they have worked through their fears, sometimes in treatment, with in behavioral psychology, and they no longer are troubled by their fear. A lot of times it's somewhere in the middle, where people still possess the phobia, but they found ways to adjust and adapt to overcome some of the problems that their phobias were causing them. People with specific phobias actually know that their fear is unreasonable, but they feel unable to do anything about it. So, for example, I have a friend who is pretty intensely phobic of snakes, and is in the process of moving to a place where snakes are likely to be something that she encounters, and she knows it's an irrational fear, that most of these snakes that she's likely to encounter are of no threat to her, and she knows this. Intellectually, she knows this, but the fear is very profound. That recognition isn't enough to counterbalance the fear that people have. What people tend to do when they have a specific phobia is they avoid the object or situation, and if they can't avoid it, then they may become overwhelmed with fear. Most phobic reactions have been in some way classically conditioned, but there are some things that we are predisposed to be fearful of. So, for example, heights and certain kinds of animals or insects, we appear to be biologically predisposed to be fearful of those kinds of events. So, in that list that I gave you of the most common categories of phobias, animals, heights, storms, water, flying, crowds, and closed spaces, many of those are also experiences for human beings that are a potential threat. So basically, what is the disordered phobia? It's when that perception of the threat is out of line with the real level of risk that is being proposed. Social anxiety disorder, as I mentioned before, used to be called social phobia. It refers to people who have developed a clear, irrational, and overwhelming fear of what are called social performance situations. So a time when you need to behave, you need to perform some act when you're being viewed by others. And this is particularly the case for times when we're exposed to people we don't know, or who we know are going to be scrutinizing our behaviors. So think about times when you have to give an oral presentation in class. This would be a triggering type of situation for someone who has social anxiety disorder, where they may shut down or they may have a panic episode in response to that kind of high scrutiny situation. As with phobias, the fear that is experienced by people with social anxiety disorder is excessive, it's unreasonable, and it gets in the way of everyday life. The fear may be connected to very specific kinds of social situations, like eating or speaking in public, or it may be more generalized to any time you have to engage in behaviors in front of other people. What can happen with social anxiety disorder is that people will start to shrink their lives. They'll start to pull their life into these very limited spheres where the person feels comfortable. So they may feel emotional reactions of worry and intense anxiety about situations that are social. This may play out in school settings, in other kinds of social situations like work settings. One of the experiences that is common is feeling intense fear of being embarrassed by one's own behavior. It can also come packaged with some physical symptoms that are associated with autonomic nervous system arousal, like having an upset stomach, sweating, dizziness, and so on. Usually those physical symptoms are associated with the experience of panic, and all of these can lead to avoidance of people avoiding social situations that prompt their anxiety. Estimates right now, about 7% of people in the U.S. report some level of social anxiety. The main explanation at the present time for social anxiety disorder is that it's primarily a disorder of cognition, although there is controversy about the origin of social anxiety. Many kids are diagnosed with social anxiety when they start to go to school, and they may experience that first sort of overwhelming situation where they're surrounded by other people who they don't know, and they're being asked to, say, for example, read out loud or answer a question in class, and that can become overwhelming. One of the reasons they're saying that one of the causes is, or one of the explanations is cognitive, is that people with social anxiety disorder tend to have some fairly distorted thoughts about what other people are likely to see when they observe their behavior. And they tend to perceive that other people will be very, very critical of them. So cognitive and behavioral therapies tend to be the treatment of choice. Now, agoraphobia is one of those disorders I wish there was a different name for, because it can kind of be misleading. Agoraphobia refers to anxiety, fear, worry of being in situations that you can't get out of that may be difficult or embarrassing. Now, one of the issues with defining agoraphobia is that in popular culture, it's believed to be a fear of going outside, and that's really not what agoraphobia is used to describe. It typically means that it's like agoraphobia tends to get attached to other kinds of anxiety disorders. So you can have panic disorder with agoraphobia or without it. And for me, it's just like, if you've had the experience of panic and intense fear in, say, a crowded situation or in a store, in a workplace populated by other people, standing in line, traveling, that panic experience in that situation may lead you to say, nope, never going in that situation again. So your life starts to shrink. And for some people, their life will shrink so small that they, in fact, don't leave their home. So it's a misunderstanding that it's a fear of the outside. It's really that shrinking of one's life because of the experience of panic in these sort of crowded, populated situations that can become overwhelming. The most common situations that people talk about in association with their agoraphobia is being trapped in crowds, standing in lines, traveling on crowded transit, like buses and trains or planes, and being trapped in a car in heavy traffic are the most common kinds of situations that people have agoraphobic reactions to. If you break the word root down, agora is kind of like a marketplace. So the idea is you're not afraid of being outside. It's actually being in crowds, being surrounded by people. So what people will do is they will just systematically avoid these situations and won't leave. If their lives shrink too much, they just won't leave the security of their home unless they're absolutely forced to do so. Estimates are that about 2% of the U.S. population would meet the diagnostic criteria. And there appears to be some behavioral and evolutionary explanations for this pattern. So, for example, we are biologically disposed to avoid situations that have terrified us in the past. It has a good purpose, right? You know, if you went to a location and it was filled with scary people who were trying to hurt you, would you want to go back there? No, you probably wouldn't. So we are biologically predisposed to stay away from places that cause us danger. So we're kind of leaning in that direction anyway. On the behavioral side, it can become this sort of shrinking your life can become self-reinforcing. So you can say, yeah, I'm not leaving my home. if I leave my home, bad things will happen. So I'm staying home where no bad things happen. So it can become sort of self-reinforcing. Panic disorder, and I've mentioned panic attacks here several times in this presentation. Panic disorder is characterized by recurrent, what are called panic attacks. And a panic attack is characterized by a sudden experience of intense, overwhelming fear, accompanied by the biological, physiological symptoms of panic. Panic attacks typically include all of the autonomic nervous system arousal characteristics, such as shaking, sweating, heart palpitations, shortness of breath, chest pain, even dizziness and passing out. And all of those experiences, they're very physical, they're terrifying, and they hurt. So many times when people have a first panic attack, they end up in the ER thinking that they're having a heart attack or that they're otherwise dying. It can be challenging to, get an appropriate diagnosis until people have had more than one or several panic attacks in various situations. The prevalence rate is about 2 to 3%. It is typically diagnosed more often in women than men. Part of the reason why is just simple sexism. Men are less likely to present to a psychologist and talk about panic as their primary problem. Women are more likely to do so because it's more socially permissible for females to express fear. Other reasons may be more biological, connected to the biological differences between males and females, but that research is ongoing. Some of the biological explanations involve alterations in levels of specific kinds of neurotransmitters that are associated with sort of the fight or flight system. So some biological arguments are that in panic disorder, people have sort of an itchy trigger where they are very quick to experience and this sort of physiological arousal and to label it as panic, and very slow for their body to return to baseline. So it's very easy for them to go to a fear state and very hard for them to pull back. So there's some evidence of abnormal neurotransmitter activity, particularly related to norepinephrine. And that, suggests that there's this series of areas of the brain that are linked in sort of a circuit that is not functioning properly. So it's very fast to trigger and very slow to pull back. Some of the cognitive explanations beyond the biological involve individuals who are misidentifying or mislabeling some of their biological states. And by doing that sort of mislabeling, and this is why it's a cognitive explanation, they're talking about their own physiological states in such a way that it can actually elevate their level of experience of panic. Panic disorder is often present with agoraphobia because it's like a coping strategy. When people have panic attacks that are unpredictable, they're sudden onset fear events, there's no real identifiable trigger, it'll just happen. What people will do is they'll look around them and say, this environment is the trigger, I'm never going to that environment again. So let's say a person has a panic attack in a crowded mall, they'll just never go back to the mall again. They have a panic attack on a bus, they never get on a bus again. They have a panic attack trapped in traffic, they never drive again. So agoraphobia can become an element that's really commonly associated with the experience of panic attacks. And some have argued that it's when people have lots and lots of panic attacks that are highly unpredictable, then agoraphobia becomes more likely as a strategy, not an adaptive one, but as a strategy for controlling the onset of panic. A generalized anxiety disorder is I would argue, one of the most common mental disorders that people have. Generalized anxiety is persistent, excessive, just general anxiety that people can't control, that occurs more days than not for at least 6 months. So diagnostically, what you're looking at is just a baseline level of anxiety, worry, and concern that's just always there. It's sort of described as free-floating anxiety. It's not tied to specific situations or objects that are triggers. It's just always there. So it just floats. So think about it this way, is like 24/7, a person with generalized anxiety disorder is always going to be worried, always going to be concerned, always experiencing just a baseline level of worry and anxiety. The prevalence rate is about 6%. It is diagnosed far more often in females than in males. And there are a variety of explanations for that. As I mentioned before, males are less likely to present in a psychologist's office with symptoms of anxiety because as a culture we tend to discourage males from talking about being fearful because it's inconsistent with the masculine gender role. But there's also some biological evidence that suggests that females, in terms of their biology, may be more vulnerable to persistent levels of anxiety. As a sociocultural argument, there may also be the fact that women, as opposed to men, based on their gender roles and based on their culture, have more to be afraid of. So there are lots of different possible causes. On the biochemical side, some recent research is focusing on the activity of GABA, which may be that the brains of people who have a proneness toward generalized anxiety may just be over-aroused and responding to the world in a persistent state of readiness for panic and response to emergency. So the idea of that's being studied by some neuroscientists is that people with GAD may have trouble getting GABA activated, and GABA is kind of the off switch for bringing those levels of anxiety down. So one theory is that for people with GAD, they just don't have that system operating that shuts down feelings of anxiety and worry when they're not warranted. Now, obsessive-compulsive disorder used to be categorized as an anxiety disorder. It no longer is, because the argument is that it's less about anxiety and much more about the obsessive thoughts that people have about themselves or about the world that surrounds them. OCD, counter to the narrative that we often see in television and film, involves recurrent obsessions and compulsions that the person knows are out of line with reality. They're unreasonable, they're excessive, and they cause disruptions in daily life. But they're not restricted to specifically the kinds of obsessions and compulsions that you're most likely to see on TV or in film. Like the stereotypical version of OCD is a person who's very highly perfectionistic, who is rigid, clean, tidy, obsessively so. That's an incomplete and in some ways inaccurate representation of OCD. The obsessions that people experience are big intrusive thoughts, ideas, impulses, and those intrusive thoughts cause fear and anxiety in the person. Compulsions are rigid, repetitive behaviors that the person feels need to be performed in order to control anxiety. The most common kinds of of obsessions. And here's the kernel of truth of the stereotype on TV and in movies. The most common obsessions are contamination fears, so fears of germs, dirt, toxic substances, but also another really common set of obsessions is a persistent fear that something horrible is likely to occur. And it could be something horrible is likely to occur to you, or that you're going to cause something horrible to happen to other people. Some of the most common compulsions are excessive hand washing, behaving, grooming, and so on. But those are not the only ones. So one common misconception about OCD is that it's always about cleanliness, neatness, hyper control of the environment, and fear of germs. That is by far not the only expression of OCD. I'll give you a concrete example. A man that I had come to campus as a speaker, his fears were largely, his obsessions were about harm avoidance. And what that means is he could see the potential for harming other people in these vivid, intrusive images in his mind. For example, he went with his family to cut down a Christmas tree at a Christmas tree farm. And basically at this farm, you walk in with your family, they hand you an axe. And his immediate first thought upon seeing the axe were intrusive images of accidentally slicing off one of his children's arms with the axe. Not that he had any intent to do it. It wasn't sort of an impulse drive. It was an intrusive thought where he had a vivid image of striking his child and blood flying everywhere. That's a harm avoidance obsession. And he was quickly overwhelmed with fear, had a panic attack, ended back up in the car while his wife cut down the tree and brought it back to the car. Other fears that he had, other obsessions that he had a lot to do with driving. He worked in San Francisco as an announcer on a drive time radio show. And if you've ever driven in San Francisco, that can be a pretty scary thing. It's not easy. So he would have to leave the house far earlier, hours earlier than other people, because what would happen is he would be driving, he would feel a bump like a pothole, and he would check his mirrors, and he would experience an intrusive image that he had run someone over. And so he would keep checking the mirrors, but the fear wouldn't go down. He wasn't convinced by what he was seeing that there was no dead body in the rearview mirror, so he would circle the block and come back and check. And then he still wasn't sure. He would circle around and come back and check. That's the compulsive part of it. If he saw a pylon knocked over on the freeway, he would have an intrusive image of it being hit by a car, flying up in the air, smashing through someone's windshield and killing them. So he would see it. He would drive by it. He would keep looking at it in the mirrors, overwhelmed by this intrusive image. He would get off at the next ramp, circle back around to see if it was still there. And he would have to do this several times. So, that doesn't have anything to do with that common image that we see on TV of a really perfectionistic, rigid person who needs an ultra clean, tidy environment. In fact, lots of people with OCD have homes that are just cluttered, dirty, and include tons and tons of stuff. Recent research suggests that there are issues related to serotonin. Now, part of this is reflective of the fact that when people with OCD take selective serotonin reuptake inhibitor medications, they do tend to see a slowdown on the intrusive thoughts. So the suggestion is that these imbalances in serotonin or absences of serotonin may have something to do with shutting down these intrusive thoughts. The serotonin activity has also been linked to other areas of the brain, particularly the orbital region of the frontal cortex. the caudate nucleus that's in the basal ganglia, the thalamus, the amygdala. All of those areas are associated with arousal and interpretation of emotion as those emotions are connected to sensory information. So, the neuro side of it is really interesting. We know that OCD tends to have a heritability factor that's decently high. So, and it's related to some other common disorders like ADHD and even autism have some things in common with OCD. Now, disorders in the DSM-5, what's been decided is they're going to have this category of disorders that are that all share this sort of obsession compulsion loop. So hoarding disorder, remember how I mentioned that some people with OCD, their homes, their living environments can often be chaotic and messy and filled with stuff. In some cases, that is the sole characteristic of their experience. They may hoard objects, just collecting objects that have little or no value. They're saving items and experiencing extreme distress when they have to discard them. And part of the cognitive component of this hoarding is the obsessive belief that the objects may have use later, that they may have utility later. And if you got rid of them, how could you use them later? So there's intense distress about that. At the same time, it can be very, very problematic because you can literally fill your house to the rafters with useless things to the point where your home becomes unlivable and unsafe. Now, research has shown that the overwhelming majority, about 75% of people with a hoarding disorder are also anxious or depressed. And some also have a co-occurring diagnosis of OCD. Most commonly, though, people with hoarding disorder also tend to be diagnosed with major depression. Another related set of disorders, excoriation and trichotillomania, are less well known, but no less problematic. Excoriation is compulsive skin picking, and trichotillomania is compulsive hair pulling. These are heavily stigmatized disorders because they tend to prompt outside observers to experience disgust. So people with these disorders tend to really be fearful of being judged by others as well. People with excoriation disorder tend to pick at their skin, leading to very slow healing and a lot of lesions, scars, and other problems, including infections. The prevalence rate is about 1 to 2%. It's much more common in females than males. Part of this is because in cultures like ours, women tend to be more criticized for evaluated based on their physical appearance, and that includes especially the face, but also other parts of the body. With trichotillomania, which is compulsive hair pulling, what people will do with that disorder is pulling hair from any part of the body, but most commonly the scalp and other parts of the face. So pulling scalp hair, pulling eyebrows, eyelashes can occur. Women are more likely to be diagnosed, primarily because women are expected to have, in our culture, women are expected to have hair, and it's a big part of the way we evaluate attractiveness in females. Baldness and the absence of hair is far more socially approved of in males than it is in females. So women are more likely to go, when they're compulsively pulling out their hair and they don't have, a full head of hair to present to the world, they may go straight to therapy. Males may just shave their heads and be done with it. not to diminish it in men, it's just that men are less likely to go seek therapy if they are compulsively pulling their hair. Now, some research does also suggest that there is a biological basis for the sex differences in these areas that may create the vulnerability, but that research is still pretty unclear at this point in time. That concludes part 2 of chapter 10.